There she is. Hi, good evening. Hi, Dr. Kashani. This is Dr.
Hello.
Bana Kashani, everybody. This is Maria Sophocles. We're doing a nice summer evening gynecology this Thursday night. And we've been doing so much you can tell I just got out of the operating room. We've been doing so much on medical abortion and on Roe v. Wade and on for June. June was Pride Month, so that had a lot of amazing topics, and we've had a fantastic summer of learning and great guests. And July, I think it's important to not forget some of the other parts of OBGYN that impact us and affect us, and that so many of my patients uh, want to know more about. So tonight's guest is Dr. Bana Kashani, who is a reproductive endocrinologist and infertility specialist in Southern California. Dr. Kashani went to medical school at the University of South Alabama and then did her residency at USC. She did a fellowship at Rutgers back in New Jersey, yay! And now she has a really lovely personalized, I'll call it boutique at the risk of overusing that term, practice in Southern California, where she really strives to personalize the approach to fertility for couples. That I can't stress how important and probably rare that is now, because so many practices are being bought by large conglomerates, and even specialists like myself or subspecialists like Dr. Kashani are then forced to sort of see X number of patients an hour a day, and kind of we get put in these robotic sort of formulaic ways of practicing medicine. And I know my practice is not like that, and we really love that. It makes the clinicians happy. It makes me feel connected to my level of care. And I think Dr. Kashani shares that. I'm sure I'm going to let her tell you a little bit about herself and her practice as well. Dr. Kashani is going to talk with us tonight about fertility options, what's tried and true, what's basic, what's new. And as always, we're happy to answer your questions as well. So welcome, Dr. Kashani. Thank you for coming on this summer evening. I know you probably, like me, have plenty of things you can be doing with your time. We really appreciate learning from you. So thank you.
Thank you so much for that introduction, Dr. Sophocles. Thank you so much for letting me be here. I have a passion for talking about fertility care and fertility. It can be a subject that is, really difficult to bring up to your friends, family. And so I just want to be able to break it down, make it simple, and help everyone understand what they need to do in case they are having a situation where they're struggling with getting pregnant, or they're just concerned about their fertility and are they going to have difficulty having a child in the future. These are things that women think about all the time. And so that's what I'm here for, to kind of just be able to talk a little bit more. And like you were telling everyone, all the listeners, my practice is different. I do really like to get to know each of my patients and couples and really delve into a little bit more about their maybe diagnosis and what's causing the background and what we can do to treat them. And every couple is different. Some people are okay with jumping right into the most successful, aggressive approach for treatment. And some really want to just take it more natural. And that's what I'm here to kind of figure out and discuss and see what's suited best for each couple.
Sure. I mean, I think that's also best, that's best practices, but it takes a really caring and compassionate clinician to be willing to take the time and to listen. So let's go right into it with sort of basic infertility. If I come to see you and I've been sent by my OBGYN because I've been trying to get pregnant for a year and no luck, and my OBGYN feels I now need more help. What's a kind of basic evaluation, and where do you start? How do you start? And do you start with the couple or just with the woman?
So usually it's great to start right away with the couple, just so we don't miss anything. What I like to tell people is that there's really usually four major causes of infertility. And if you break it down into these four things, categories, it makes it a lot more simple to understand what to do. So there can be a male factor component. That's number one. And so what does that mean? We need to make sure there's enough sperm and that they're swimming well and that they're shaped normally. And so a semen analysis is a test that can be done by taking a sample of ejaculated semen, looking under a microscope, and just making sure everything looks okay. And so we never want to exclude that, because at least a third of cases of infertility have some sort of male factor component. So for that, male factor is number one. We would do that. Now, the three other causes are all related to females. And so two of them are something related to the anatomy. So what is that? There can be a uterine factor or a tubal factor. And so what does that mean? So the uterus is where pregnancy would implant and grow. And so we want to make sure that the inside of the uterine cavity, it's like a little room, right? And that's where the baby's housed for 9 months. We want to make sure that the shape of that uterus is normal, that there's nothing abnormal growing inside it, like a fibroid or a polyp or something that can impact implantation. So that's something that should be checked via an ultrasound, or also another imaging test called a hysterosalpingogram, or HSG. So that's number two, uterine factor. Number three is the tubal factor. So again, part of the anatomy is that off the uterus, there's these fallopian tubes. And the fallopian tube is where the sperm and egg actually meet. They make contact. And so if the fallopian tubes, imagine they're these long tunnels, if they're blocked, then you can't have conception, sperm and egg won't meet. So we need to check to see if the tubes are open. And there's different ways that that can be done, but one of the most standard ways is something called an HSG, or a hysterosalpingogram. The other way you can diagnose if the tubes are open is via a surgery called a laparoscopy, where a camera can be put through the belly button and you can look all around and put dye inside and see if the tubes look open and healthy. So again, that was 3 out of 4: male factor, uterine factor, tubal factor. And then the final thing that's so important is the ovarian factor, or the ovaries. So first, we have to understand, does a female have regular menstrual cycles? I can't stress how important this is, because having regular periods without being on birth control or hormones is the body's way of saying that all the hormones from the level of the brain all the way to the ovaries are functioning well. And that will tell you if you are ovulating usually. So ovulation is very important. It happens 1 day a month, usually in the middle of a cycle. And so we want to see if you are ovulating. But beyond ovulation, in terms of the ovaries or the ovarian factor, we also want to assess egg quantity. We want to see how many eggs does each patient have approximately, or what we call ovarian reserve. And we want to make sure, are they average for their age? Are the numbers maybe above average, which is great, or are they below average? So these are the fertility assessments that we can do to kind of see what the ovaries and egg quantity look like. And I'll probably talk a little bit more about those tests, but there's 2 tests that are blood tests that help us give an understanding of the ovarian factor, or egg quantity. And then the other is an ultrasound to look actually at the ovaries and count what's called an antral follicle count. And I can go into each of those in detail if you'd like, but
yeah, I think that's so much already, and that's important. But I think the most important thing you said, because I think male factor, everyone gets that, and all the women watching are going to go, great, I can have him do that. And then I think the uterus and the tube, if they just think of an HSG as sort of, well, we'll call it an X-ray that is sort of live, where dye can be injected and spill through the tubes, and we can see the dye spill out of the end of the tube. Yes, it's open. The dye doesn't spill out of the end of the tube. Perhaps that tube is blocked. And the uterine shape, same thing. The dye is going to kind of outline this beautiful little triangle that is the home that the baby grows in. So I think you did an awesome job with that. And the ovarian function the ovarian reserve, it's really two things. It's an AMH level, which you can talk a little more about if you want, and by ultrasound. But I think the single most important conceptual thing you said is that if someone comes to you or me and says, "Hi, I have regular periods," that in and of itself is fantastic news. That for a
Absolutely.
woman to have regular periods, many levels of hormonal function have to be working in concert and have to be appropriate. So women sometimes come to me and they say, "I'm getting married next year and I'm really nervous. I want you to do every test in the book, throw everything you can because I've got to know." And I will, not to be tough, but I'll say, "Look, you have regular periods every month. And that in and of itself is a really great predictor of your fertility." That, I guess, in your age, would you say? I mean, are those two, or is it just
It's going to come. The next thing is obviously age, and one of the most
sure,
important things. So
sure.
everything related to chances of getting pregnant, whether you do treatment or no treatment, really comes down to age. And so we are meant to have children when we're in our 20s. And the reason why is the egg quality is best the younger you are. Despite whatever we do and how healthy we are, egg quality does decline from our 20s to 30s, and especially in our 40s. And so that's why it gets harder to get pregnant after the age of 35, and especially after the age of 40. And in addition, even if you got pregnant, unfortunately, there is a higher chance of miscarriages as we get older as well. So
And a
age
higher
is
chance
so
of
important.
genetic issues, right? A higher chance of chromosomal issues, rather.
Abnormalities, yes.
Yeah, sorry. Um, got it. But if a woman comes to you and she's 30, or let's say 35, and she's having regular periods, even without any testing, what kind of reassurances could you provide by just knowing that she has regular periods? Or is that just far too basic for a subspecialist to
No,
get?
no, 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 no. So most women who are less than 35 with regular periods, who are actually attempting to try to get pregnant, like they're having
Yeah.
unprotected intercourse, at least 75% and up to like 80% should be pregnant after the first year.
Okay.
And more than 90% should be pregnant after 2 years. But if you're nearing that time frame where it's been over a year, then I think there's no harm in getting at least an evaluation at that point to pinpoint and see if there's any reason that can be identified that could potentially be treated, or have at least a reason to understand the background as why pregnancy hasn't taken place.
Sure. Makes sense. And so for those women, you would do some basic blood work and you'd do an ultrasound and you'd
Yep.
get the semen analysis. What would that blood work entail?
So I would like to ideally check a few fertility hormones. One of them, as we discussed, is AMH, or anti-Mullerian hormone. This hormone can be checked at any time in a menstrual cycle, so it's not specific to a certain day. And what it is checking for is essentially this hormone is made by the cells that sit around your eggs. And the more eggs you have, your body will produce higher levels of this hormone. The higher the number, the higher the egg count. And there's averages for women. So we expect women who are in their 20s to have higher AMHs than women who are in their 40s. So that's one blood test. The other blood tests are ideally done when you get your period on the second or third day of the menstrual cycle. So these should be done at a specific time point so that they can be interpreted appropriately. One of the tests is called FSH, or follicle stimulating hormone. This is an incredibly important hormone made by the brain, and it acts every month to signal to the ovary to make an egg or a follicle grow and mature until it's ovulated and can be released. And we don't want the FSH to be high. We want the FSH to be at least less than 10, because it's telling us that the minimal signal from the brain is sufficient to make the ovary ovulate. When the ovary is not functioning at its best, or egg quantity has decreased, the brain senses a problem. And that problem makes it rev up its production of FSH. And unfortunately, when we see high FSHs, it's telling us the brain knows the ovaries aren't working as well. And so it's not a good sign for fertility.
Mm-hmm. And this is what we see in menopause too. The brain, I tell my patients, the brain is yelling louder at the ovary, you know, and
work, make that egg. Yes.
yeah. So that's great. Thank you. That helps women understand. So many women say, someone ordered this and I don't know what it is and I don't know why. And I think it's really nice when patients actually understand what you're ordering and why in the beginning of the cycle. Um, Oh, is Clomid still is that still the most commonly used, ovulation induction agent, or do people use letrozole more now? Or maybe we should talk about what an ovulation induction agent is, and then we can talk about.
Sure. So, ovulation induction agents are either pills or injections to get women to ovulate. If they don't ovulate, or it's given to some women who actually do ovulate and have regular cycles, but we want to give a super boost, like give an extra boost of ovulation, maybe to release more than one egg. And so these are hormones Clomid is a pill that you take for 5 days of the month, and it tricks the brain into making more FSH with the purpose of helping you ovulate if you don't. If you do ovulate, it can increase FSH levels so that you ovulate maybe 2 eggs a month or 3. And the purpose of that is that the more eggs you release, then the higher chances you have every month of getting pregnant. There's just more targets for that sperm to find 2 or 3 eggs rather than just 1 a month. But Clomid is still very commonly used. I would say more so than letrozole, but it's definitely that letrozole has become in favor, especially in women who have polycystic ovary syndrome or PCOS. Letrozole is very effective, and that's another pill form that helps trick the brain into making more FSH.
Why this is for me, why is letrozole better for a PCOS patient?
So it's been studied particularly in overweight or obese PCOS patients because they have such high testosterone levels. Letrozole blocks the conversion of testosterone to estrogen. And so that ends up making less estrogen in the body. Again, the brain signals, oh no, there's not enough estrogen, and it works better to help induce ovulation in those women. So they've done studies where the live birth rates are higher after letrozole use in women who have PCOS and particularly are overweight
Yeah. I think we should take a little segue to PCOS itself because
big topic affects a lot of women. So
of course, and some women know they have it, but they may not fully understand its impact on fertility. And other women, frankly, don't know they have it, but they're watching this saying, oh, my periods are irregular and I have trouble losing weight and I have oily skin and da, da, da. And for those women, this could be a nice aha moment. And for the women who have the formal diagnosis, they may want to understand better the relationship between PCOS and fertility. So let's just start with PCOS, what it is and what causes it. I'm sorry to make you our walking encyclopedia, but
I love this. So polycystic ovary syndrome, or PCOS, is unfortunately not the best name for what this is, but essentially it is a condition that affects 10 to 15% of women. It's not a small number. And what is the most classic thing that people say is their periods are irregular. And irregular means it's not like their cycles come every 28 days, 1 month, and then 30 days, 1 month. It's that their cycles are either coming more than every 35 days, and some women even skip months of getting their period, 2 months, 3 months, 4 months. So their cycles don't have any kind of pattern of coming every 28 days or 30 days. So that's number one. The other thing that's seen oftentimes in women with PCOS is they have many, many different hormonal abnormalities or variations. And one of the most important things that we see is higher levels of the male hormone testosterone. So all of us have some low level of testosterone that's normal for our bodies, made by the ovaries and the adrenal glands. But in women with PCOS, their testosterone levels are unfortunately a lot higher, and this causes some problems. So what does it cause? It can cause pretty bad cystic acne that can be on the face or on the back. And then also women complain of having increased hair growth in kind of a male pattern. And they're not just little peach fuzz on the face. It's really like thick, long hairs. If you're noticing you have to pluck your chin, you're having hairs down your neck. hairs on the breast, thick, long hairs that are growing on the belly or upper thighs. This is sometimes due to a hormonal abnormality of increased testosterone. So that's one of the other classic findings with PCOS. And then, of course, the other way we can diagnose it is through a vaginal ultrasound. And we can look at the ovaries and see if they look what's called polycystic. And polycystic essentially just means there's tons of follicles or eggs. There's a lot of them. So there's all these black little dots or circles on the ultrasound and ovaries. But the problem with PCOS is that those eggs don't mature and grow and develop and ovulate in a given month. And they just kind of sit there and sit there and sit and don't release the nice hormonal patterns that happen when women ovulate and get their period regularly. So it's if anybody has irregular periods or notices increased hair growth or acne, definitely go talk to your doctor to see if you could have PCOS. But the final diagnosis of PCOS, and this is so important to know, is a diagnosis of exclusion. So what does that mean? We can't just label everybody who has irregular periods with PCOS. We first have to make sure that irregular periods are not from something else, which can be other hormonal problems like a thyroid problem or something you're born with that's related to an enzyme deficiency. So this is why you should see somebody and do an extensive workup just to make sure you do have the true diagnosis of PCOS. It's not from something else that could be treated.
Right. And I think it's important. I've had patients come in and their pediatrician or their internist just said, well, your periods are irregular, get on the pill and they'll be regular. And that's not untrue. A pill could regulate the period, but that doesn't mean they've either been diagnosed with PCOS or even have PCOS by exclusion, or it has even been discussed. So I've had a number of people with all the clinical stigmata of PCOS, and they, I don't want to speak negatively about the physicians. I think they were doing what they felt was helpful, of course. Sure. But the solution doesn't mean we have the diagnosis. So I think there's nothing wrong with advocating for yourself and asking. And if your clinician's not sure, or they say, well, isn't the whole deal just to get a regular period? Perhaps you need a referral, to an OBGYN or to a reproductive endocrinologist. And by the way, let me just make sure Dr. Kashani is we'll say an OBGYN on steroids. She's double board certified. So she did her OBGYN residency, and then she did a fellowship in something called reproductive endocrinology. It's let's just say it's the OBGYN version of being an endocrinologist, right? I mean, that's sort of a simple dumbed down way of putting it.
Specialist.
I can't tell you how many people don't actually understand what that is or how you're different from an OBGYN. And I think it's critically important. And I think, there are OBGYNs that are busy and they're quick to just put someone on a pill. And I think it's valuable to have the correct diagnosis. Even if you don't have PCOS, that's valuable too, because it helps you get the treatment you need specifically for fertility, or to get the optimum treatment to help, whether it's your skin, your hair, your weight. I mean, all these things are so wrapped up in this and similar diagnoses that I think appropriate diagnosis is really important.
I can't even stress that enough. I just had a patient this week who, unfortunately, when she was younger, was thought to have PCOS from her irregular periods and was diagnosed with that. She lived outside the country. And, for years and maybe she did. Obviously, we don't have records, but she was seen several times by, her doctor, and they assumed the same irregular periods, PCOS. And unfortunately, by the time she came to me, I found out that her irregular periods right now at age 40 are not from PCOS, or actually because she's almost going into menopause. And for the last couple of years, she was just continued to be treated for PCOS, which that wasn't the cause. So definitely, it's important to really get a true evaluation and make sure that's the right diagnosis instead of just assuming irregular periods are PCOS. Right. Which most people they are, but
yeah, it is. It's a super common diagnosis. So happily, most people are even if they're not properly diagnosed, that is ultimately what we find. But that's a perfect segue to another diagnosis called POI, premature ovarian insufficiency. all of these diagnoses, by the way, I don't mean to sound like sexist or whatever, but
No,
they're all these well-named things
yeah,
to make us sound like we're about to die of something, or that we have four heads. But I think POI is something else that I certainly see a lot of, and I know you see a lot of. And
yeah,
it's important for people to understand this big horrible name, but what it is, it's not certainly not as common as PCOS, but it's not rare. And the reason you might care about it so much, and we both care both, but from a fertility standpoint, it could be devastating. But
yeah,
I also care in a preventative health standpoint
for
when I
sure.
think about bone health and heart health. And so let's just cover that. I think we should cover it real quick.
So, unfortunately, premature ovarian insufficiency means you go through menopause early. And the actual diagnosis is when you go through menopause, which means no period for 1 year, and you're under the age of 40. Now, some women actually may not have true premature ovarian insufficiency, but at the age of 30, we start seeing very irregular cycles, and we see that they have very low ovarian reserve that we call diminished ovarian reserve, or they have a very low egg quantity. And basically, what it comes down to is, for whatever reason, and we can go into the reasons why this can happen, their egg quantity has gone down so low that it's at the levels of menopausal women. So it's like you're in your fifth, your ovaries are acting like they're in their 50s, and they're not ovulating and releasing an egg. You're not getting your periods, unfortunately, normally, and you probably don't feel well. You don't have the nice hormone estrogen in your body that's protecting your heart, like you said, protecting your bones, and helping with things like libido and being able to have intercourse with lubrication naturally, and all of these things. So it's a very difficult diagnosis. And for fertility purposes, it often means you may not be able to successfully conceive using your own eggs. And it could be that you may have to consider alternative options like third party reproduction, which means maybe using someone else's eggs or embryos, or adoption.
And should those women get an FSH? Is that how you do it? Or do you also check their AMH and check other things? If they're coming to you, not necessarily just for fertility, but they're miserable because they're having some hot flashes and they're having vaginal dryness, and their cycles are irregular, how do you work that patient up?
Yeah, so I often will see their FSH. I'll check their estrogen levels. Sometimes there's some hormonal function estrogen within the bloodstream, so we see that. I like to do an ultrasound to check their uterine lining, see if it's actually thickened. Has there been estrogen around recently, or is it very thin? And then definitely we talk about the benefits of hormone therapy like estrogen and progesterone, which is needed to protect you against endometrial cancer. And we, want to make sure we also do preventative measures against osteoporosis and cardiovascular disease. So those are the things that we look at. I don't necessarily always check an AMH, but sometimes it can help be confirmatory. If the AMH is almost zero, then it just adds to the clinical diagnosis.
Right. Especially if they're coming to you to understand whether they could have a baby. I get a lot of women like this, and they are newly married, or they're thinking of having a child now because they haven't before. And so it's I think it's important to understand that POI, while it can be a devastating diagnosis, you may not have that diagnosis. You may have, what do we call it, a warm up to POI, or
Diminished ovarian reserve, I guess we would call
I
it.
know that's equally long.
Yes.
But it's frustrating, and women feel, you know what I find, they feel they don't like getting this diagnosis. They
No,
feel older, and often they're women who are otherwise healthy, fit, attractive.
completely. They're like, I'm so
That's
healthy. I have the best diet.
right.
It's frustrating, very
Yeah.
frustrating.
Yeah, and they look at you like, I'm doing everything right, and I'm actually a partner at my law firm, and I'm a triathlon runner, and you're like, I know you're doing everything right, but your ovaries have decided, not to
Yeah.
behave or whatever. But POI, I think, is important because like I said, for for certainly for a fertility sense, if you have a woman 40 or 42 and she wants to conceive, and she is diagnosed with POI, it's well, you'll tell us it's very unlikely or it's going to be very difficult to conceive. And from my standpoint, she has about a decade head start on beginning the acceleration of loss of bone, on the acceleration of cardiovascular disease, and things that we see that happen after 51, the national average age of menopause, 51 and a half. So we see heart disease in women lagging behind men, thank goodness, until the 50s, in which case it accelerates because of that lack of estrogen. So if you get a woman with POI and she's 40, and she doesn't want to have a baby, don't pat her on the shoulder and say, no big deal, or don't tell the patient. And if you're the patient, don't accept a doctor just saying, well, you don't want to have kids, so it's no big deal. You need to proactively think about what your bone and your heart are not getting, and Dr. Kashani mentioned the need for estrogen and progesterone if you have a uterus. Why do we say that? She mentioned it. She said to protect the uterus from uterine cancer. That's because if we give estrogen, remember the uterus is used to seeing estrogen and progesterone sort of be the yin and yang, estrogen promoting growth of the endometrial tissue, progesterone inhibiting or limiting that growth. So if we just give a woman from age 40 to 50 estrogen, thinking we're doing a great job helping her bones and heart, without that progesterone, we're actually doing her a disservice. And she could be at risk for endometrial cancer or hyperplasia, an abnormal growth that isn't cancer. So sorry to
No,
segue, but I feel like it's so
so
important to hit these things.
absolutely.
So, gosh, we've already covered a lot, which is fantastic. What do you want to tell us? What could you tell us about egg freezing if a woman wants to come and do that because she doesn't want to conceive until she's climbed all 7 peaks or made partnership, or she's single now, but blah, blah, blah. We have 100 different reasons why women may want to do this. And thank God it's because they're mostly breaking glass ceilings and doing all kinds of great things with their lives.
Yeah.
But what do they need to know? What does a patient need to know?
So for sure, one thing that's important is egg freezing is a great way to preserve your fertility in case you are trying to wait to conceive. As I said, we're meant to have children in our 20s, and most of us don't anymore. And even most of the time in our early 30s, people have no trouble getting pregnant. But if you're waiting to get pregnant till after 35, I think it's important to consider egg freezing as a backup. Okay. And it's nice to know that it's just a backup. You may never need it, but in the event that you do struggle or you really try to get pregnant later, you have something to fall back on. However, it's also important on the other end to stress that it's not a necessary guarantee. A lot of people say it is an insurance policy. It is, but there's no absolute guarantee that it will pan out. So that's an important concept to really grasp. It helps, but one thing, we just don't know how those eggs will eventually thaw and fertilize and result in a future baby. But egg freezing, what I tell patients is, if you're single or if you're in a relationship and you're between the ages of 30 to 35, I would start considering getting a baseline evaluation. And what does that entail? It comes back to those tests I was talking about, which are the ovarian reserve tests. Let's check your AMH. Let's see where your egg quantity is and average it amongst other women of your age. Are you way above average? Are you below average? Are you right at average? And then also do an ultrasound to check your actual follicle count. Same thing, see where you're at compared to other women of your age. And the reason I think this is so important is that somebody could come in who's 31, not really thinking about egg freezing because they're still on the younger end of fertility. But we find out that, their mom went through menopause early. And all of a sudden we check your hormones and the egg quantity actually matches more like somebody who's in their 40s, which means the AMH is low, the follicle count is low. Well, that 31-year-old may benefit very highly of freezing her eggs now, so that in 3, 4, 5 years, she doesn't have such a decline in egg number and goes into early menopause like her mother. So those are the things that we want to look at. The other thing is that sometimes I'll have people come in and they're 33 or 34 and they just want to check their numbers, see where they're at. We find out things look good and they're in a relationship. And I tell them, okay, well, maybe we don't do egg freezing just yet, but we can at least have you check again in 6 months. Why 6 months?
Yeah.
Because everyone's egg quantity, if we think of a graph, we start here, eventually over time, it's going to decline and go down. But if you check your numbers here and things look solid, and you check again in 6 months and they're still about the same, at least we can say, okay, in 6 months, things are pretty stable.
Right.
But there are some people that after the age of 32 or 33, they have a big drop in their egg number. Then that clues us into, well, maybe we should do egg freezing because, again, in 3 to 5 years from now, what if this number looks worse and I lose out on that opportunity?
Got it. Got it. So that's a really helpful, I think, sort of time frame so that women in their early 30s can understand. And help me understand and help them understand a little better the relationship between when your mom went through menopause and when you may go through menopause.
Yeah, it's not 100% correlated, but there is something to be said about a genetic or heritable component. So if your mom went through menopause early, that is a red flag for you that you may have less eggs and also go through menopause early as well. If your mom went through menopause late, that's great. But again, there's still factors in your environment that may not guarantee you'll go through menopause late. For example, smoking already makes you go through menopause 2 years earlier. And there's other factors, like if you had surgery on your ovaries in the past, that can make you go through menopause earlier, or if you had to have chemotherapy or something like that. But there is a relationship to the age your mother went through menopause.
Right. And of course, some women, they don't know their mother's passed away or their mother had a full hysterectomy with the ovaries removed or something like that. But I always tell women it is a tendency, but it's not a clear cut.
For sure.
It's not super clear, but I love the idea of kind of 2 data points to kind of measure. And because one is really just a snapshot,
Absolutely. It's just one snapshot in a moment of time. We can't predict the future. So again, if you're on the fence about doing it, the best thing is check your numbers and then reassess.
What about cost and coverage for this? Is this ever covered?
Yeah, there are actually so many companies now, different employers that are including an egg freezing benefit or a fertility benefit for this. So that's really nice. For example, even if you work at Starbucks, they have an insurance benefit and company. Obviously, the big name companies like Google and Facebook are covering it. So
Right.
that's really, really great. However, for some women, if you don't have coverage, you could look at about a $6,000 to $10,000 cost for egg freezing per cycle. And in some women, you can achieve that in just one cycle, being able to freeze enough eggs. For others, it may require several cycles. So it just depends, again, on your fertility and ovarian reserve.
Got it. Thank you so much, because it's a big question mark for so many women. They've never thought about it. Now they're thinking about it, and they're not sure whether they have to mortgage their home or have to, whatever. And so many of them just sort of put it as a pipe dream. But it's cool to know that some companies will cover it anyway. And then same with donor eggs. If someone says, okay, there's nothing there. I had chemo, I had radiation, I have nothing. I want to have a child. What's the best way for them to explore egg donation? Not getting donor eggs.
Yeah. So first of all, there are support groups that I think are really nice to hear other people's journeys about egg donation. So that's a nice starting point. There are therapists that are made available specifically to talk about egg donation and third-party reproduction and what that involves. And then obviously a fertility specialist. So egg donation can come directly from egg banks where women have already donated their eggs. eggs, and you can search through profiles to see if somebody is suitable for you, and matches something that, you know, you feel like could be something you would consider in terms of starting your family. Versus there are agencies that can look for a specific donor that's very much similar to you as well. If you're a particular ethnicity and you wanted to make sure you pass that along to your child. So there's different things that can be done and different types of donors' eggs that are available. And again, I think the best thing to do is kind of get out there and be part of a support group, because that way other women can guide you appropriately and what helped them come to that journey. It's a whole new journey, but it really is a beautiful, beautiful option for many.
And what about, you know, let's look at the same thing for sperm, especially a same-sex couple who says we want to have children. What's the best way for the same thing, support groups and things like that?
Yeah, absolutely. Sorry about that. Just 1 second.
No, don't worry about it.
Can you repeat that question just for a moment?
Yeah. Don't worry. Yeah. So sperm donation. So same thing. If a couple wants to do that, the same thing. Their banks, their companies. Can you help guide a couple to
Absolutely. I always want to be involved in the process. And so what I tell people is whatever you're selecting, please send me over their profile of the donors. And thankfully now with the technology we have, sperm donors, egg donors, they do undergo genetic screening for certain conditions. Yeah. And so you want to make sure that that donor is compatible with your partner. And that way we know for sure if that's an option. And I always want to be involved in the process and guide my patients appropriately.
Right. So last topic really quick is just carrier screening, right? Because if you're going to have a sperm donor or you're going to have your partner even, you want to understand if they're Ashkenazi Jewish or if you have thalassemia minor, what should you be?
So this is so important. We have such great advances in technology. And so what that allows us to do is to take a blood sample and be screened for like 200 or 300 conditions. Now, obviously, we're not affected by those conditions. We inherited one copy of a gene from our mom, one from our dads, and then we're presumably healthy. However, we may not know that we're a carrier for one of those abnormalities. And if our partner or a donor is also a carrier for the same condition, you can pass that condition to your child. And that could be something like muscular dystrophy, cystic fibrosis, or even deafness. And so we have the ability to test for those conditions and to be able to hopefully minimize the risk of having children affected by these severe conditions. So I think it's something that the American College of OBGYN, or ACOG, strongly supports. And I think it's a great idea for couples trying to get pregnant to seek out these options of genetic carrier screening.
Perfect. Thank you so much. I feel so glad that we covered so many topics, and I really appreciate the time you took. Dr. Bana Kashani, thank you so much.
I love talking about this. It was, you're so knowledgeable already, but I hope I was able to add a little bit to that.
Well, you added tons, and my viewers, thank you so much. We'll post this on YouTube tomorrow, so you can put it on your practice, and that way your own people can hear and see, and throw tomatoes at Dr. Sophocles or whatever. And we do this every Thursday or every other Thursday, so I'm sure we'll get you back on at some point. And we wish you all the best, and we thank you so much for joining us.
Thank you so much for having me. It's been an absolute pleasure, and thank you for doing what you do and helping educate so many people. So have a great evening. Bye-bye, everyone.